Chiropractic management of headaches in children. Although there have been a number of RCTs and even systematic reviews regarding specific headache types and their response to manipulation, there is far less evidence regarding headaches in children and their response to manipulation. A new study is the first RCT designed to determine the effect of manipulation in not for a specific headache type, but for headaches generally in children. The title of the publication is Effectiveness of Chiropractic Manipulation versus Sham Manipulation for Recurrent Headaches in Children Aged 7 to 14 Years, a randomized clinical trial published in Chiropractic and Manual Therapies in 2021. The annual prevalence of recurrent headaches ranges from approximately 5% among 3-year-olds to more than half of the children around puberty. So why is this important? Because headaches interfere with school performance, social life among peers and family, participation in play and sports, and also children with recurrent headaches report higher levels of stress and depression compared with children without headaches, and recurrent headaches predicts severe headache syndromes later in life. How often do children present to chiropractors with headache complaints? Well, headaches are the presenting complaint with 11 to 20% of school-aged children and adolescents in chiropractic practice. This study was conducted in northern Denmark at 2 clinics, one chiropractic clinic and one pediatric specialty clinic. Inclusion criteria included children ages 17 to 14 who have experienced at least one episode of headache per week for the previous 6 months and had at least one musculoskeletal dysfunction in the spine, pelvis, and/or TMJ. Exclusion criteria were examination findings requiring immediate referral, contraindications to spinal manipulation, previous treatment for headaches within the last 3 months, or failure to report pre-randomization baseline data. So what was the profile for these children? Well, the mean baseline pain level was a 5 out of 10, and approximately half the children had experienced recurrent headaches for 1 to 3 years. They reported most often a few days per week. However, 13% suffered from headaches almost every day, and an episode of headache lasted typically from 2 to 12 hours per day. The typical region of onset varied among children, but the headache was often located at the forehead. The most common concomitant symptoms were nausea, dizziness, light and sound sensitivity, and although this study did not distinguish headache type, this pattern points to migraine headaches. Neck pain and the use of computers or TV were the activities most often thought to cause headache, whereas sleeping was the main activity easing the headache. Again, a pattern matching migraine headache. The children and their parents reported weekly through text messaging answers to the following questions. How many days has your child had a headache this week? Choose a number between 0 and 7. How will you rate the pain on a scale from 0 to 10, where 0 is no pain and 10 is the worst pain you could imagine? And how many pills for headache has your child taken this week? 0 for none, 1 for 1 to 4, and 2 for more than 4 pills. And after 4 months follow-up, after completion of the trial, they answered the following questions. How satisfied is your child with participation in this trial? And how has the headache changed since your child started the treatment at the chiropractor? 1, almost gone or disappeared. 2, much better. 3, slightly better. 4, the same. 5, a little worse. 6, much worse. And 7, worse than ever. And 3, in this trial, there have been 2 groups. Do you think that your child was in group 1, who had standard chiropractic treatment, or in group 2 that did not have standard chiropractic treatment? Please answer 1 or 2. So how were outcomes determined? They were the average values during the pre-treatment period and the final 4 weeks of the study for the 3 variables based on the weekly SMS questions. The final outcomes were interpreted as the difference between these means. A 4th outcome was the global perceived effect based on the SMS question number 2 after 4 months. However, what changed was that the researchers used what they called an adaptive design, where based on interim findings, the priority of outcomes could be shifted. The primary outcome variable was modified to the change in the proportion of weeks with medication use. The definition of the 4-week pain scores was changed for intensity to take into account only weeks with at least 1 day of headache. Rather than illustrating the average intensity, this reflects the intensity of the headaches when present. Equally important outcomes of highest priority were number of days with headache and pain intensity, followed by global perceived effect, and then medication. There were several phases to the studied trial. After a 4-week pre-treatment period verification of at least 4 episodes of headache, a screening for inclusion-exclusion was done by the investigating chiropractor. This included standard neurologic and orthopedic examination, as well as examination for biomechanical dysfunctions in the spine, pelvis, and TMJ. All participants and their parents received oral and written advice regarding regular sleep, diet, and exercise believed to be beneficial to headache patients in general. Participants were then randomized into the real high-velocity, low-amplitude manipulation group and the sham manipulation, which was low-amplitude, low-velocity, gentle pushes in a broad area away from the spine, which were given with no cavitation, while a deactivated activator held by the chiropractor would produce a clicking noise. So what happened to the children who did not improve or get worse? Children in the chiropractic spinal manipulation treatment group who reported little or no effect or worsening of their headaches after treatment were offered a consultation with a pediatrician. Children in the sham manipulation group who reported little or no effect or worsening of headache after the trial period were offered free chiropractic care similar to the care delivered in the spinal manipulation group. And to the results. For the number of headache days, both groups reported fewer headaches after 4 months follow-up. However, the average reduction in headache days was 2 times more in the intervention group. The effect size was moderate, and about 1/3 of children displayed more than a 50% improvement in the number of days reduced versus about 25% of the children in the control group. The number needed to treat to reach 20% improvement was 7. So what does number needed to treat mean? If you took the 2 groups and looked at 6 participants in each group, there would be no difference in the reduction of headache days. But when you treated the 7th person with real manipulation, this is when you would see the benefit. And now to the results for pain intensity. Both groups improved with pain intensity equally, with no statistical difference between the 2 groups. And to the results for global perceived effect. Improvement in the mean or average GPE score for the intervention group was 3.2 and 2.6 in the control group. The difference in mean scoring was significant, with a value of 0.61, which is a moderate effect. 43.4% reported improvement in the intervention group and only 22% in the control group. The number needed to treat was 5. And some other interesting findings, 84% of the children in the intervention group reported side effects, and in the control group, it was 75%. Side effects reported were mild in nature, most often soreness, headache, and fatigue, and they were typically of short duration, 0 to 2 hours. This, of course, is curious given the procedure used for the sham treatment. Another reminder of what is called the nocebo effect, where patients have been shown not only to improve through placebo, but may perceive harm through nocebo effect. At the 4-month follow-up, 62% of the intervention group and 59% of the control group guessed the correct randomization group. There was a distinct difference in the number of treatment visits, with a median of 11 in the intervention group and 7 in the control group. But wait, hopefully you caught what was unexpected here. Both groups improved, and although the number of headache days was less for the intervention group, there was equal improvement of pain intensity. This is a very similar finding to many other studies and does beg the question, given there is no control group, is this natural history? Secondly, is there something common between groups that accounts for this improvement? Could it be the encounter itself? Could it be the contact with the patient physically, or, as usual, the expectation of improvement? The authors state, quote, The difference in effective treatment between global perceived effect and frequency and the lack of effect on intensity might imply that frequency and pain intensity alone do not adequately capture improvement as experienced by the children. This indicates that there are elements of improvement which are not captured by the investigated outcomes, unquote. But what they must also consider is either a placebo effect that is strong or that something in the sham treatment is similar enough to real treatment that it actually does have an effect. As always stated, more, larger randomized controlled trials need to be performed.